Hi, my name's Jim Hill. I'm the Associate Chief Medical Officer at UH Parma Medical Center, and I'm a critical care anesthesiologist. Today I'm going to be talking to you about airway management during the era of COVID-19 and how that some of our practices that we've had for a long time may have to be modified in order to account for this new variable. So today's objectives, we're going to discuss what is COVID-19, just give a brief introduction of that. We're going to discuss proper personal protective equipment during airway management in the era of COVID-19. Discuss what airway management would look like in suspected COVID-19 patients, and then outline the mechanical ventilation strategies you would use for a patient with suspected COVID-19. So what is COVID-19? So COVID-19 is SARS-CoV-2, which is basically a virus similar to the SARS virus from the early 2000s, but with a zoonotic origin presumed. So it's believed to have an incubation time of 5 to 14 days, and the primary transmission is believed to be respiratory droplet, but it may have a component of aerosolization as well. So that creates a lot of implications for people who are going to be working around the airways of people who are suspected of having COVID-19. It affects a lot of different organ systems too. So the one that we're going to focus on today is primarily respiratory. Quick progression from respiratory distress to pneumonia to acute respiratory distress syndrome in some of these patients. There's also the possibility of acute cardiac decompensation too, with cardiomyopathy being reported in some of these patients as well. Patients experience acute kidney injury and renal failure, so that's something to be on the look for. And they also have hypercoagulable states, which may be tied to things like stroke or pulmonary embolism. So it's a disease that really affects a lot of different organ systems, and it's something that, as we kind of go through the next slides, we're going to discover that has a lot of implications for what you do. So you can't talk about COVID-19 without first starting with how to protect yourself. As a healthcare provider, it should be the utmost focus to not only protect your patient, but also yourself as you're concerned about managing these patients. So really the mainstay of personal protective equipment for COVID-19 begins with the N95 mask. It's effective at filtering out the majority of aerosolized particles. But there's also N95 alternatives because not everyone is going to either be able to fit in an N95 or has an N95 readily available. And we're going to cover what some of those are as far as the half elastomeric respirator, the full face respirator, and the PAPR device. So starting with the N95s, they filter out approximately 95% of airborne particles. And some of them have an exhalation valve, some of them do not. Most of the healthcare ones tend to not have that exhalation valve. But we are using some industrial equipment now with permission of the CDC. It forms a tight seal over the face, nose, and mouth to help it aid in not having those aerosolized particles make their way into your airway. OSHA assigns an assigned protection factor of 10 to these masks, and that's on a comparative scale, as you'll see here in a few moments. If you are using this for intubation or airway management, you're going to want to wear a surgical mask over it, basically to help prevent contamination of that mask as you do manage the patient's airway, as intubation has a high risk of aerosolization of particles. Next, we're going to cover the half-mask elastic respirator. And it's a reusable device that has filters that can be exchanged on either side. There's a variety of manufacturers for this device too. This particular one happens to be a 3M manufactured device, but they're all very, very good devices. They have a silicone seal on the inside, which is very good for long-term wear, as well as getting a great seal to help prevent aerosolization of particles into the healthcare provider's airway. It has an assigned protection factor of 10 according to OSHA, and that's on a relative scale that you're going to see here in just a few minutes with the upcoming slides. All right, the next personal protective equipment we're going to talk about is the elastomeric full face respirator, which I have right here. And this is, again, another 3M device. It's reusable, but it has an integrated face shield too. And so you can see that it has the reusable filters on the side here, but also has a larger silicone seal kind of around the device, which allows you to get an even better seal than you would with the elastomeric half-face respirator. So the fit testing is required for this device too. Again, this is slightly different fit testing for an N95 too. It requires that you check the seal when you put it on for positive and negative pressure leaks. The assigned protection factor according to OSHA for this device is approximately 50. So it's in the setting of airway management, this is probably a mainstay of therapy for people who are in conditions that may not have a PAPR or something like that. Then you have the powered air purifying respirator, or the PAPR, and this is a battery powered suit. It has an assigned protection factor of up to 1,000, depending on if you're wearing the full suit or the half suit. Fit testing is not necessarily required for this device, but it's of great utility in people with facial hair who may not be able to get a proper fit with an N95 mask or an elastomeric respirator mask. And it creates positive pressure within the suit that helps push the particles out to prevent aerosolized particles from entering in. Then you have things like isolation or surgical mask. While these are effective in routine contact with patients, for high aerosol generating procedures such as intubation, it's not really an appropriate thing because the amount of aerosolized particles coming in will not be sufficiently stopped with an isolation or surgical mask. It'll be effective against droplet-sized particles, but not necessarily those aerosolized particles. Then you have additional personal protective equipment. And so one of the things that I have here is a pair of very tight-fitting goggles. And again, these have a silicone seal around them to get a very tight seal against your face, because there is a possibility that of ocular contact with the aerosolized particle may lead to contraction of the virus. So it's something that healthcare providers, again, need to be very cognizant of and take good lengths to protect themselves for. Also, utilization of gloves, especially double gloves for the person doing the intubation, as well as an isolation gown and a recommended hair covering. And so if you're wearing a cloth surgical cap, you need to cover that with a disposable device as well, as not to cross-contaminate yourself when you don and doff personal protective equipment. Donning and doffing of personal protective equipment is potentially one of the highest risk procedures for a healthcare provider. Because after managing an airway, there's a high amount of aerosolized particles that have come out, and those are stuck to any personal protective equipment you're potentially wearing. So you need to be very cognizant of how that material was put on, but also taken off as well. So first thing is that if you're using a disposable N95 respirator, you want to discard that following an aerosol generating procedure. Presumably because the amount of virus coming back at that mask has made it relatively unsafe to reuse. You want to discard any respirators that have been contaminated with blood, secretions, respiratory or nasal, and other bodily fluids that the patient may have. You're going to want to discard respirators that have come into close contact with in any area that may have a high amount of potentially infected patients. You're going to want to consider using a clean shield or face mask over the N95 respirator to shield that. You're not going to reuse it, but it potentially helps when you go to take off that to prevent you from cross-contaminating yourself. Perform hand hygiene when you remove any particular part of PPE. That'll help prevent cross-contamination. And remember, there is a high risk of cross-contamination when you remove personal protective equipment, so you need to do so in a very safe manner to prevent yourself from being exposed to the virus. So now we start to talk about airway management during COVID-19 and what that looks like. So there are a number of professional societies that have put out guidelines on this, but I think one thing that's important is you may not know which patients have COVID-19, so you need to consider and assume that every patient that you're going to manage the airway of with respiratory difficulty may have COVID-19. So you need to maintain a high level of suspicion with that. You need to identify respiratory distress early, as there's the quick potential for decompensation in these patients. And another thing is that there is a reported incidence of laryngeal edema with these patients too. So airway obstruction may occur in these patients, and you need to be cognizant of that as you manage the airway moving forward. Oxygenation management during COVID-19. Higher flow rates lead to an increased risk of aerosolization. That has led to limitations on some modalities such as high flow nasal cannula or BiPAP therapy for some of these patients. Literature on this continues to evolve. Low flow nasal cannula likely doesn't increase substantially the risk of aerosolization. For high flow oxygen, non-rebreather appears to be the mainstay of therapy. Approximately 15 liters, we're relatively confident that the risk of aerosolization is not high. CPAP, BiPAP may increase the aerosol risk, especially if you're using a passive exhalation circuit and the exhaled air is just bleeding back into the atmosphere of the room. So you're going to want to make sure on those you're especially using viral filters to help prevent aerosolization of the virus. And make sure that any place you can put a viral filter on these devices that you're doing so to try to prevent contamination of the surfaces as well as the healthcare staff. Oxygen therapy, the recommendations are use the lowest acceptable flow rate. Get the best possible seal around the mask, again, to prevent cross-contamination. And if applicable and available, the patient should also wear a surgical mask. This will help prevent the droplet-sized particles from being expressed into the atmosphere. The severity of illness for COVID-19 varies greatly. About 80% of the cases that we're seeing don't require hospitalization, minimal pneumonia, and the patients will recover. About 15% of the cases, the patients become hypoxemic on room air and may require additional supportive therapy as well as hospitalization. There's 5% of patients, though, who become very critically ill with this, and these are the patients who quickly can decompensate and they will end up requiring intensive care resources. They also may have some respiratory dysfunction or multi-organ system failure. So how do you evaluate the respiratory status in these patients? Well, do they have refractory hypoxemia to what you're doing? If you're placing the patient on 6 liters nasal cannula and they're not improving, that's a sign that the patient may quickly progress into full-blown respiratory failure. Is their mental status being altered? In addition to hypoxemia, are they becoming hypercarbic or are they beginning to tire out with that increased work of breathing that you may see? And how difficult is it anticipated to be to manage this person's airway and intubate if necessary? These are all things that you need to consider very early in the patient's course. So preparation for airway management again begins with proper PPE adherence. Advanced preparation of that equipment and pre-packaging of that equipment. You don't want to take more equipment into the room than is absolutely necessary because a lot of that equipment may need to be thrown away during a high aerosol generating procedure. You need to minimize the staff that's in proximity. And this is contrary to a lot of the way we practiced airway management before. With that, you usually want a lot of help around. This is a protection of staff measure, so you want to minimize the amount of people to the absolute necessary people in the room in order to manage the person's airway effectively. And you want to achieve appropriate pre-oxygenation. The induction of intubation and anesthesia in this patient needs to be done by the most experienced person in the room, just because there is the high potential for cross-contamination as well as the high potential for difficulty in intubation, and these patients lack the physiologic reserve to survive prolonged periods of apnea a lot of times. So they must do so with double gloves too to help prevent that cross-contamination. Video laryngoscopy is recommended for these patients, but not every situation may have video laryngoscopy available. So the greater distance you can apply between yourself and the patient's airway during intubation, the less chance you have of contracting the virus from aerosolization procedures. The recommendation for these patients is that they have a rapid sequence induction. Due to shock states, these patients may require cautious administration of fluid or a vasopressor prior to giving drugs for intubation. Recommended induction agents in these patients tend to be etomidate, ketamine, or midazolam due to the hemodynamic stability associated with that induction. High-dose rocuronium or succinylcholine to quickly achieve paralysis, which will allow you to more quickly intubate the patient, is also a recommendation. It also helps prevent the patient from coughing during mechanical ventilation and intubation, which may help spread viral particles. Cricoid pressure and avoidance of positive pressure until the endotracheal tube is in place and the pilot balloon is up. There's also an indication here for modified rapid sequence induction, which would be very similar to RSI, but with the allowance for bag mask ventilation. It would be recommended that you would have a two-person technique for bag masking as to assure that you have a proper seal around the mask not to leak exhaled air into the room. It's recommended that you use a viral filter on your ambu bag in order to prevent contamination, and use low pressure and tidal volume technique when you're doing this so not to increase the amount of aerosolized particles. The difficult airway management scenario, it's probably best to try to delay intubation until you're in a setting that can provide definitive care, such as an emergency room, if you're able to. A bougie may be tremendously beneficial in these patients if they have anticipated supraglottic edema. And rescue ventilation would be indicated with the insertion of an LMA or another supraglottic airway to help prevent a poor seal around the bag mask ventilation that the person's getting. Confirmation of your endotracheal tube placement. Once the endotracheal tube is in place, you're going to inflate the pilot balloon. You're going to use capnography. It's best if that capnography is already in the circuit with the ventilator, so as you're not having to switch between a ambu bag and a ventilator. Auscultation can occur once the pilot balloon is inflated, and it will help confirm endotracheal tube placement. It's not a necessity if you have capnography, but it helps to tell you if your endotracheal tube is too deep or too shallow. Following endotracheal tube placement, it's important to remember that the hypoxemia may continue to be severe. So the patient may be properly intubated, but it may take a matter of an hour for that patient's oxygen saturation to recover from the initial intubation attempt. Cleanup after this is to remember the proper donning and doffing procedures to prevent cross-contamination. Secure the laryngoscope blade in a glove, that's the purpose of the double gloving, and then a complete wipe down of surfaces in the room where the intubation occurred. It's helpful in these situations to also have a buddy that helps you remove the personal protective equipment to help prevent cross-contamination of yourself. For ventilation, after intubation, it's preferred to hook directly up to the ventilator rather than on the ambu bag and switching back and forth. And the purpose of this is to prevent aerosolization of viral particles. If disconnect is needed, use of a surgical clamp, or some institutions are using a piece of tape in order to prevent aerosolization of particles during switching out ventilator circuits. An HME with a viral filter should be used during any ambu bag transport or mechanical ventilation. Then you have mechanical ventilation strategies. There's extensive literature on how to ventilate ARDS patients, but the applicability of this to COVID-19 is still relatively unfounded. So in the meantime, what we are doing is we are practicing low tidal volume mechanical ventilation, which is a mainstay of therapy for ARDS patients, which a lot of the COVID patients will progress to. To calculate that, you're going to want to use 4 cc's per kilo of predicted body weight, and you can see the formulas to do so. It's important not to use the patient's actual body weight, as morbid obesity may lead to hyperinflation of the lungs. Also, you're going to want to maintain a plateau pressure of less than 30. You're initially going to start at 100% FiO2 and with a goal oxygen saturation of 88 to 92%. PEEP management in these patients is also a focus. So one of the things that you're going to start, I routinely start patients at 10 to 12 of PEEP, but you may, in the severely hypoxemic patient, may quickly have to add PEEP in order to effectively be able to oxygenate your patient while in transport or in the emergency room. So with that, now we've kind of established what the principles of airway management are in the COVID population. Let's run through a case study of a patient of how quickly they can decompensate and what that management might look like. So we have a 62-year-old male with a past medical history of hypertension, alcohol abuse, and smoking. Fairly healthy, normal gentleman. Patient has been recovering from a surgical procedure at an extended care facility. He has a 3-day history of cough, fever, and now presenting with a worsening shortness of breath. During the EMS run, the paramedics note that the patient appears ill. He's febrile, he has a slightly elevated heart rate, slightly hypertensive, increased respiratory rate, and is about 80% on room air. BMS providers place the patient on 6 liters of face mask, and oxygen saturation improves to 88%, and they transport this gentleman to the emergency room. Over the next 2 hours in the emergency room, the patient progressively decompensates more, becomes more hypoxemic, increased worker breathing, and is transitioned to a non-rebreather. But despite the best efforts of the emergency room care team, the patient appears to be tiring out. Chest x-rays obtained showing a bilateral interstitial infiltrate pattern. Labs show that the patient has a new onset acute kidney injury, as well as elevated troponin and a positive COVID-19 test. During the ED course, the decision is made to intubate the patient. The staff in the room is limited to the anesthesiologist and the ED physician, the 2 most expert people in airway management in the hospital. Patient undergoes rapid sequence induction with etomidate and succinylcholine, is intubated with a glide scope and attached directly to the ventilator with capnographic capability. The initial ventilator settings are 400 cc's, respiratory rate of 16, PEEP of 18, and an FiO2 of 100%. Due to hypoxemia, the patient's PEEP is increased to 22 prior to ICU transport. A central line and arterial line are then placed. The patient is then admitted to the intensive care unit. Patient requires periodic paralysis and proning for the next 7 days. Mechanical ventilation is continued for 16 days. The patients require continuous dialysis due to ongoing acute kidney injury. The patient also developed a stress cardiomyopathy with an ejection fraction of 20%. After a total of 22 days in the ICU, the patient is then moved to step down following extubation. One of the things that's kind of come out of the COVID-19 era is an increased awareness of a modality called proning. And this involves taking a patient from the supine position and moving them into a prone position on their belly with the use of padding and a face pillow. The patient is kept proned for 12 to 16 hours per day. It's indicated for patients with refractory hypoxemia and acute respiratory distress syndrome. This may improve mortality in ARDS, and it may shorten duration of mechanical ventilation. It also works to increase the lung recruitment and decrease lung compression, so you allow more alveoli to be oxygenated and ventilated during this time. So conclusions for today are that proper PPE is an essential part of protecting healthcare workers during airway management in the COVID crisis. Removal of personal protective equipment has a high risk for cross-contamination for healthcare providers, so it's important to be very meticulous in the way you do it. Video laryngoscopy and rapid sequence induction are important practices during the COVID crisis, and the familiarity with low tidal volume ventilation and oxygenation may help improve patient outcomes. So with that, thank you very much for your time, and have a great day.